speaker today. Pretty sure you're familiar with his work. Read his paper, met him. He is a professor of emergency medicine and vice chair of research at Stony Brook University. Published a lot of research, and his work has changed the management of a lot of things that you do in emergency medicine, especially in the management. So we're pleased.
Thank you very much, and it's a pleasure to be here. I don't know if you guys know, but actually, there are a lot of my friends here in the audience, but also we've gotten many of your graduates the last couple of years. Tremendous contribution. So keep sending all the best residents to our place. So I know there was a little bit of a confusion, I think, when the emails went out as to what exactly we were talking about today, but we decided to focus on abscesses, okay? I know one of the articles went out, some of you may have actually read it on cutaneous wounds and abrasions and burns, but maybe at another time we'll talk about that. So we want to spend a little bit more time on the abscesses, and instead of trying to cram in like everything, burns, lacerations, abrasions. Okay, so certainly I like this to be interactive. If you have any questions, stop me in the middle. You know, I like a lot of questions. It makes us think a lot, and don't hesitate. So let's move forward. First of all, I want to say, you know, I have no conflicts of interest or disclosures, and most of what I'm going to be discussing today, you can find in the recent article that we had on management of skin abscesses, also with Dave Callan, who's a emergency physician, but also an infectious disease specialist out in UCLA, who's done a lot of research on abscesses and infections, especially in the ED. All right, so here's a typical abscess, and question is, what would you do on the left? Okay, what's the treatment for that? Drainage?
Maybe.
Okay, are you sure there's pus in there?
No.
Huh? Ultrasound might be good. What else could you do if you're not really sure what's in there? Aspirate the needle, okay. And then there's another example there. I think there's a lot more like kind of cellulitis. And a lot of times patients come in where they have an abscess of cellulitis. So how do you treat that? What's the most common organism causes abscess? Staph aureus. And what's the most common organism that causes cellulitis? So what is the etiology of that? You've got an abscess in the middle and a lot of cellulitis. Do you give them antibiotics for staph, for strep, for both of them? Okay, so some of the questions that I hope to address today is how reliable is the physical exam in distinguishing between cellulitis and abscess? Because of course, the treatment is different. One is medical and one is surgical. And then what is the role of needle aspiration? Someone mentioned that. And how many of you routinely suture up your abscesses after you drain? Anybody? Okay. How many pack abscesses? Okay, do you always pack abscesses? And how do you pack it? You put like a little bit of liquor, you kind of shove in, 3 feet of Admit it. Most of you want to put in the whole pack in there, right? Who gives antibiotics after every IND? Anybody? Okay, so there are a bunch of cowards in here, right? Bunch of cowards. What if the patient has HIV infection or they're diabetic? Then you give antibiotics? Maybe. Okay. Who cultures every abscess? Okay. And you ever think about decolonizing your patients? The patient comes in the 5th time for an abscess. So they're probably colonized. You send them home and euphorosin into the nasal. No?
Bleach baths.
Bleach baths? Yes. Dilute bleach baths? Before hexamine? Anybody? All right. So these are some of the things that we're going to address. So just kind of background. Remember that abscesses are certainly one of the most common things we see in the emergency department. And in hospitals like yours, which are inner city hospitals, you're going to see a lot more abscesses. I actually went to medical school and practiced in a inner city hospital. I used to see 5 or 6 abscesses a day. Do you see abscesses every day in the emergency room?
Yep.
Now we see a lot less, at least out of Stony Brook. So, but overall, we do know that the incidence of abscess is on the rise. And of course, more and more of these abscesses are being caused by community-associated MRSA. So that's certainly changed the bacteria. And MRSA in most parts of the world is a major cause of these skin abscesses. And the question is, does that change our management in any way? So certainly, just to get everybody on the same page, an abscess is an accumulation of pus, the dermis, the cutaneous tissues. Traditionally, it's red, it's swollen, it's tender. It's often fluctuant. What does fluctuant mean? Is there any medical students here? Any medical students? No one's raising their hands. Okay, but what does fluctuant mean? It's soft. So it's a rotten piece of fruit. You push your finger in there and you can feel it mushy, right? So that's fluctuant. It's really soft, and that's like the pus inside. And in many cases, the diagnosis is straightforward. It's obvious. There's pus coming out of it. And certainly when you put a knife in there and you get a lot of pus, that confirms the diagnosis. But there are a lot of times where the abscess is very deep, there's a lot of cellulitis, and there's a lot of induration. So when you press on it, it's really stiff. You're not really sure, is that just edema? Is there pus in there? And a lot of times we end up putting knives into the skin, and we get very frustrated. The patients get frustrated. They're waiting to... And you say, did you get anything? You got like a little bit of serosum. Oh yeah, we got a lot of pus. Right? You don't tell them, oh, this was completely useless. And just torture them unnecessarily. But who hasn't done that at least once or twice? Okay, but it is frustrating. There are other definitions of furuncle is an infection of the hair follicle. An abscess is an infection anywhere in the dermis. And carbuncle is when you get coalescence of a lot of furuncles, often in the back of the neck, and then you have openings in many different sites, typically. Okay, so what is the epidemiology? This is already fairly old, 2009. But basically, we looked at the data from a very large database that the CDC puts out, and we showed that the incidence of abscesses had more than doubled over a decade, despite the fact that ED visits had only increased by 20% or something like that. But abscesses are generally seen in young adults, and antibiotics are actually prescribed in half the cases of abscesses, and about 10% to 12% are admitted every year.
Those are uncomplicated abscesses?
Well, what is a complicated abscess?
Well, no associated cellulitis?
Well, it doesn't define it really. You give an ICD code, and it's either cellulitis, it's abscess. I mean, most people will say abscess. They don't give two codes. There's a lot of problems with that in the study where it's based on coding. At any rate, this is another study, a little bit more recent, that looked at skin and soft tissue infections, which kind of lumps in both abscesses and cellulitis. And it accounts for about 1% to 2% of the visits. And again, they showed that there was an increase over time. So people are seeing more abscesses, although we really aren't seeing it in, we're more of a suburban setting. We don't really see tons of abscesses, but certainly in the inner city periods, we see that. So there is a rise in the U.S. in general. Now, what about the microbiology? So oftentimes it's polymicrobial. Usually, though, we see Staph aureus. Why do we see Staph aureus? These abscesses, because they reside on the skin, they reside on the hair follicles, and when for some reason there's a breakdown in the barrier, or either physical breakdown or because of the immune system, they gain entry into the skin, and then depending on what type of exotoxins they release, they'll either produce a cellulitis, expanding cellulitis, or more necrotic, necrotizing infection, which often is pus and abscess. But there could be multiple infections. Certainly in certain areas of the body, like the perineum or perianal or vulvovaginal, we see a lot more gram-negatives and anaerobes, again, because the flora in that area has those types of organisms. And certainly there are more or less common ones like Pseudomonas, as well as various fungi and other organisms. So this was a study that was done a couple of years ago where they looked at 11 EDs over a period of like 2 weeks in 2004, and basically they collected cultures from patients who presented to the ED with abscesses, and there they found that 76% had Staph aureus, and of those, 59% were MRSA. And at the time, about 100% was susceptible to rifampin and Bactrim, and there was pretty good susceptibility also to clindamycin and tetracycline. Okay? What was very interesting is that patients did really well if they had an abscess. It didn't matter if they got any antibiotic, and it didn't matter if they got the wrong antibiotic. So what does that tell you? You don't need antibiotics. That's what it tells you. Okay? But that was interesting. Because we talk a lot about, oh, you got to give them, Bactrim or doxycycline, and they know. But it probably doesn't really matter. There are risk factors for MRSA in particular. Certainly, people who are in very close contact with each other, either in the military, in gyms, when they're sharing needles, razors, other sharp objects, and certainly patients who have all the various immunocompromising conditions. But what's interesting about MRSA, community-associated, is it's not necessarily the immunocompromised. Okay, it can occur in really young, healthy people, and we hear about outbreaks in high school, in colleges, and again, especially when people are sharing close quarters, or they're sharing, lasers or towels or whatever. And certainly, many of these bacteria, the MRSA does colonize the skin as well as the nasal mucosa, and so they really are just waiting to pounce on us as soon as we have a break in the skin. So how does MRSA infection occur? Well, it's divided into 4 different stages from a pathophysiological standpoint. So first of all, what happens is you get systemic dissemination. So bacteria enters the bloodstream and disseminates, and it releases all kinds of toxins and products that protect it from the immune system. So for example, it has this staphyloxanthin, which basically causes quenching of reactive oxygen species. And how do white blood cells kill bacteria? Basically what happens is they engulf them, and then they produce a lot of reactive oxygen species, like hydrogen peroxide, which basically kills the bacteria. But if the bacteria is secreting agents that counteract that, they're going to be less susceptible. Also, the bacteria secrete all kinds of proteins that coat the bacteria, making it more difficult for white blood cells to engulf them as well. So there's this general dissemination, and then in the second stage, the bacteria, a small number initially, locates to the area of the abscess, and that causes, again, because of secretion of a variety of proteins, recruitment of inflammatory cells, which release pro-inflammatory signals, which worsen the local infection, which then basically leads to this large mass of bacteria during this third stage within a couple of days. And the virulence of the bacteria is related again to a variety of different proteins and enzymes that are released. And what's very typical about the abscesses is that there's a lot of the pus is very thick. And that's because the bacteria cause activation of fibrin, the release of fibrin, like a clot, which creates this kind of pseudocapsule around the bacteria, which protects it from the white blood cells. Okay, but what would be a consequence? So if the pus of MRSA is very thick, because there's a lot of fibrin, what type of therapy do you think would not be very useful? Huh? Antibiotic. What else?
Systemic.
Okay, what else did someone mention here that they'd like to do to abscesses? Needle aspiration. So unlike an abscess, for example, you go, there are a lot of intra-abdominal abscesses. We send people now to CT. They do CT-guided, drainage. But for abscesses from MRSA, it doesn't work very well always because the pus is extremely thick because of the high fibrin content. And so a lot of times needle aspiration is not really very effective because we just can't suck out that thick pus from the abscess. And then the fourth stage, the abscess matures and either may rupture and disseminate, or eventually the patient is healed. And then there's this really cool picture which basically shows this in a pictorial of, the first stage creation of local abscess, then the mass gets larger and larger and protects itself from the local immune system, and then there's dissemination. So just a little bit about the pathophysiology. So let's go to the first question, which was, how reliable is physical exam? So in many abscesses, it is quite clear-cut. Not to say that it always isn't. But this is one of the studies that looked specifically at 350 kids who had 370 skin lesions, and they had a pediatric attending, and a pediatric fellow assess independently and try to decide. The question was, do you think that this abscess is right? And they put it in, at night, will their pus come out? And the agreement wasn't really that good. Okay, the kappa was 0.39. Kappa measures agreement between two observers, and usually if it's less than 0.6, it's not really good. Less than 0.4 is pretty lousy. So they didn't really agree a lot. And so the agreement was better in older kids than babies. And it really wasn't affected at all by the level of practitioners. So it wasn't like the attendings were better than the fellows at a center. Again, which tells you it's not always easy. Again, when you have this patient with a lot of cellulitis, a very deep abscess, with a lot of induration, it's hard to tell what's going on there. So obviously someone mentioned ultrasound, and I love ultrasound for soft tissues. And this is a study that looked at 40 adults with suspected abscess. And basically they did ultrasounds, and this is what you see in an ultrasound. You see an anechoic region where you have a fluid collection, which is the pus. And basically they showed that the ultrasound had very high sensitivity and decent negative likelihood ratios compared to clinical exam. In fact, clinical exam has slightly higher positive likelihood ratio. So what's the likelihood ratio, positive and negative? Anyone want to say, what does it mean, positive likelihood ratio? Anybody?
Oh, they better know.
You can ask for sensitivity.
They better know.
Everyone knows that.
So given the positive result of the test, the likelihood that it's going to be a true positive result.
Now that's a positive predictor. Okay, but what's the difference? So the likelihood ratio actually summarizes both sensitivities and specificities, and then given what your pretest probability is. So when you see the patient, you might say, oh, this is clearly an abscess, or it's only like 10%. Then you do a test, and based on whether it's positive or negative, that will affect the post-test probability. And so if the likelihood ratio is very high, generally over 10, then it significantly increases the likelihood that given a positive test, the patient actually has the disease. A likelihood ratio of less than 0.01, 0.1, less than that, then the likelihood that the patient who you didn't think had the disease actually doesn't have the disease is very low also. So in between, it's not great, but certainly the likelihood ratio negative for the ultrasound is pretty good. It's less than 0.1. So if the ultrasound is negative for pus, you really should never be cutting the patient, okay, because you can see it very well. And it's certainly better than clinical exam. So certainly, if you have a clear-cut case where it's fluctuant, you can see pus beginning to come out of it, it feels really, really soft and squishy, you don't need to do an ultrasound. But if it's kind of firm and you're not really sure, what do we usually do? We say, oh, it's not ripe yet. Okay, so we give it, and we're really busy, we'll look at the chart rack and say, I don't want to do this, it's taking a long time. Okay, we'll give you some warm soaks and antibiotics, come back in 2 days on his shift. Let him stop opening up the abscess, right? Have you ever done that where you think maybe there's pus, but you just don't want to do it? So you kind of make an excuse. There really is no reason for excuse. And a lot of times we think that there's no pus, but there really is. And sending that patient home on antibiotics and warm soaks is not doing anyone a good service. They're going to come back again. They're going to have more pain. And so that's really not necessary. This is another study that looked at the effects of ultrasound on management of patients with cellulitis, where they thought, well, maybe there's an abscess, but they weren't sure. So these were 126 patients. These were adults as opposed to the other study, which was children. And again, they had soft tissue infection of the skin, but it wasn't clear that they had an abscess. So what they found was actually that in half of those cases where they thought there probably wasn't an abscess, there was pus. And in most of those cases, when they actually stuck a knife in there, pus came out. Okay? And so it really did change their management. And not only that, it also changed the management. There were some people, they were convinced there was pus, and when they looked at the ultrasound showed no pus, and they didn't really have to do drainage, which they had been prepared to do. So what's better, CT or ultrasound?
Ultrasound.
So this is a study by Romolo Gaspari, who was a graduate of Stony Brook, actually. He's at UMass now. And basically, he reviewed 612 patients who had an abscess, and they found among those 65 patients who had both a CT and an ultrasound. Okay? Now remember, this is a retrospective study. Only 10% had both a CT and ultrasound, so there's certainly potential for what kind of a bias? Selection bias. So we don't know if these cases really represent most cases. But regardless, this is what we have. And basically what they found was that the ultrasound was more sensitive and this CT was a little more specific. Okay? But the images were better with ultrasound. So basically ultrasound is certainly as good as, if not better, than CT, although this is the example they gave in the article, which I don't think is a great example, but here you see a CT in the perineum up at the top, which is pretty obvious. And then you see an ultrasound that's not so obvious, but I couldn't change the color. But this is basically the abscess. So we really don't ever do CTs, except, I guess, you know, when it's in the neck and it's more complicated, if it's a peritonsillar abscess, those ones we do. But usually the simple skin abscesses, ultrasound is certainly more than adequate. Not only that, you can use the ultrasound to guide exactly where you're going to make your incision. It's not always exactly where the point is. You know, you got to have like a little postule where you think that's like the center. And you might have flocculations, different pockets, so you know exactly where to go. So it really does change. But a lot of times what we'll do also is we'll drain an abscess, we get a little bit of pus, we're happy, we send the patient home, but there was a big pocket down here which we missed. Okay, and the patient's just going to come back a couple of days later. And you know, the biggest mistake we have is not putting the knife in deep enough. That's what I see a lot of residents. They go into the room and say, I tried, there's nothing. I take that knife, you know, I take their hand, I shove it down, you know, another 2 centimeters, and all of a sudden, you know, the gates of heaven open up. You should be wearing a mask. So here's an example on the left. You can see an abscess at the top there, pretty superficial. On the middle, you can see, well, there's a little pocket there, but then there's a bigger one down over here. So what if you only drain that one on the top? Okay, then it's not good enough. But if you know that there's also a big pocket there, you can actually aim in such a way to open up all the loculations. And then, of course, what is this? Cobblestoning, which is typical of cellulitis. So when you see that, don't ever stick a knife in it. You know, it's pretty clear cut to see. It's very easy to see. Obviously, you're going to be using the linear transducers, the high frequency, to make the diagnosis. Again, multiloculated abscess. You might have gone in, you know, through this one, and then you forgot. You didn't know there was more pus, so the patient's going to come back. The other one is pretty straightforward in the middle. Again, you see one single abscess. You also know the depth, okay? So that's very superficial, the one in the middle, right? So you know you can measure about how deep it is in the skin, and that way you know how far to go. And again, the classical cobblestoning, where you see edema around muscle and soft tissue, and there's no abscess. So you really, again, never want to be putting a needle or a knife into that cellulitis. And in fact, drainage of abscesses is extremely painful. We did a study many years ago. We compared the pain of various procedures, iatrogenic procedures that were done in the ED. The single most painful was NG tube insertion. And I actually inserted an NG tube yesterday. How many of you use topical anesthetics when you put in NG tubes? Okay. How many of you never use topical anesthetics? Some people, okay. You know, oftentimes we just want to get it over with. And sometimes you can do it. But it is very, very painful. So I do encourage you to prep the nose, put in some vasoconstrictive agent, put in some topical agent, anesthetic, and anesthetize the throat as well. At any rate, it is pretty painful. And that's why if you're going to drain an abscess, you need to get adequate anesthesia. And certainly consider, especially in young children, especially in areas that are very sensitive, perianal, whatever, that you may need sedation, procedural sedation, to do it, or even take a patient to the OR. I mean, it's the best thing to do, because the problem is, if you try to drain an abscess and the patient's uncooperative and they're moving, then you're not going to drain the entire abscess, and then they're going to have to come back again, and all that pain was for nothing. So really, it's one of those procedures where sedation is certainly preferred and should be used if needed. Okay, and all right, so we talked about needle aspiration. So the question was, a lot of people, what they were doing, especially when we didn't have an ultrasound, But even with an ultrasound, if you come in, you're not really sure, you stick a needle in there, you get some pus, okay, you avoided a procedure, theoretically you also avoided a scar. And so the question was, what's better? Ultrasound-guided needle aspiration, so it wasn't just sticking the needle in blind, it was seeing the pus, guiding the needle, aspirating with 18-gauge angiocath or 16-gauge, fairly big. And so they randomized patients to simple IND, 54 patients got that, and 47 had an ultrasound-guided aspiration. And you could do multiple aspirations if you wanted to. And basically, they looked at the resolution of abscesses 7 days later. And what they found was that the needle stuck, basically, as you can see, the majority, only 26%, a little bit less than that, of the abscesses had resolved. The failure rates were dismal. Look at that. So needle aspiration doesn't really work very well. And even they did that with confirmation with ultrasound. So they saw that they took out the pus, everything looked good, and most of those patients came back. So needle aspiration really is not the way to go. Okay? And part of it, as we said, is probably because it's very viscous, the pus, because there's a lot of fibrin in that. So that's one of the reasons. Now, who do I do needle aspiration on? There are patients who are like, do we really have to put a knife in it? And I say, well, I really think I should drain it with the knife, but if you want, we can try to do it. 26% did succeed. So it's something that you can consider in patients who are really hesitant about it. But I don't really recommend needle aspiration as a primary therapy. Yes.
How about aspiration hidradenitis?
Hidradenitis is a different, animal. We're not going to talk about hidradenitis at all today. Okay. Those are very complex. They often come back. And those patients really should be referred to a surgeon, and they often require extensive excision of the whole area. So I'm not really going to comment. Okay, so the question is, what type of an incision should you make? So this is a study that compared patients where they did linear incision versus unroofing, where they cut out a piece, and basically there really was no difference. There's no difference. Now, how long should the incision be? What do you usually do? So someone went like this.
1 centimeter. 1 centimeter.
Well, a lot of people are very aggressive with their abscess management. Okay, you go in there, you make a really long incision, pus comes out, you pack it, everyone's really happy. Except it takes a long time for that to heal. There's an ugly scar. So now with ultrasound, when we have eyes, I make one small incision. I take the 11 blade, I make a puncture wound. That is it. If I need to break down loculations, I go through that with a clamp or something if it's adequately anesthetized, and through that one small incision, I break down all, because I know exactly where all those pockets are. So why would we leave the patient with this really long incision? We don't need to. There's no reason to. It's like doing an appendectomy, just making a really, really long incision, just in case you can get your elbows in there. But you can really do it through a small incision too, right? And the longer the incision, the more suffering the patient has, the worse the scar, the longer time it takes to heal. This is an interesting study that they published where basically they had patients who came in, 300 cases, and 3 EDs who had abscesses, and they put on a topical anesthetic cream. And what they found was that in a few patients, they actually drained spontaneously. Okay, but it was really a very small number, and they still needed to drain it. So I don't think that this should be our primary care, putting on a topical anesthetic. But I guess it makes sense to put on a topical anesthetic if you're going to then be anesthetizing it further. Okay, so it's just an interesting finding that they found. Now, there is a different technique. A lot of people have been concerned about this aggressive, big incisions that really cause a lot of morbidity for patients. So they have looked at ways to use different types of incisions, less aggressive. And here what they did is, it's called the incision and loop drainage. This was a retrospective study where basically they made 2 small incisions on either end of the abscess, and then they put a drain through that, and they tie like a Penrose. And basically, what they found was that only 5.5% was required reoperation. Okay, so that's another method that's been described. Basically, what it is there's your abscess. Instead of making a large incision, you make 2 small puncture wounds, you stick a clamp through it, and then you take a Penrose or some catheter or something, you pull it through, and you tie it. Why do you need that? You can just make one tiny little incision in the middle, look with your ultrasound, and drain it all. So I think it's kind of silly. I've never done it. But there are a lot of people who still are publishing. This is another one. This is not a nipple. This actually is an abscess. And again, you're seeing how they put in the clamp, they pull in this ribbon or the loop, and they tie it. But I think that's just a lot to do for nothing. You know where the pus is, you go for the pus. Occasionally, you may have to make a larger incision, but I don't really see any benefit to these so-called less invasive methods. So this is another study that looked at this method. Again, a retrospective chart review, and they compared 134 patients who had the traditional open IND with 85 patients who had these small stab wounds and the subcutaneous drain. And basically, they felt that the outcome was just as good. And actually, they thought that the cosmesis was better, but they didn't measure it. So like, we did this, we thought it was good, and you should do it too. I don't think so.
Surgeon.
I don't know if it was surgeon. Where was it published? It was published in the journal. Yeah, it may have been. Okay. So what about primary closure? Okay, so remember that when we talk about closure, there's primary closure where you have a wound, you immediately close the wound, like suturing. Secondary closure is you let the wound close on its own, usually by formation of granulation tissue, reepithelialization, or delayed primary, where you basically say, you know what, I'm not sure if this wound is clean enough to close. Let's leave it open for 2 or 3 days, bring the patient back, and if it's still non-infected, let's just suture it up. And some people recommend that, for example, dog bites are great. But it turns out, actually, that starting in the 50s, in England, people were closing abscesses, okay, which, you know, it was counterintuitive to whatever we weren't. Is you have pus, you don't want, why aren't you closing it? Why would you not close an abscess? What's the argument?
It's a trade.
Continual drainage. Okay, so it's going to reaccumulate. Okay? But if you've just removed all the pus, why would it reaccumulate? You just took a dirty wound and you cleaned it out. Okay, how is it that we send patients all the time with like liver abscesses and intra-abdominal abscesses? We send them to CT. They do, you know, they put in their needle, they pull it out, and they don't take the patient to the OR. So how is it that patients have this terrible abscess in their abdomen who can drain and not even make an incision? And yet on the skin, oh my God, if you close up that pus, you're going to die of sepsis tomorrow. You know, does it make sense to you? Does it make a lot of sense? So anyway, so actually, so we did a systematic review. We found 7 randomized clinical trials, including almost 1,000 patients in the literature over the years. Half of them were closed by primary closure, so they drain the abscess. But the key is you have to drain it well. You can't just do a, you know, partial drainage. You have to make sure that all of the pus is out. Okay? And actually, in this particular systematic review, almost all of the cases were anogenital. You think, oh my God, all abscesses, which are the ones that you'd be afraid to close? It's the ones around the rectum. But they did drain them in the operating room. So at least they knew they could scrape it out. They knew it was really, really clean. And what did they find? Well, it took half as long to heal. So when you suture it, it's closed and it's healed in a week. If you leave it open, especially when you make these long incisions, which most people do, it takes 2 weeks.
What was the definition of healing? Closed?
Healing was closed, epithelialized, yeah, closed. And recurrence rates were actually not statistically significant, but certainly were not higher after primary closures, right? So it seems that if it was me, it's like, I wanted to suture. I mean, why do you have to wait with this big open wound if the recurrency rates are not higher and it heals much faster? Yes.
And all these were washed out as well?
Some of them were washed out. Most were. You know, they don't always describe exactly. But in the OR, you can do whatever you want. They really could drain it, scrape the edges, wash it out. You know, certainly they knew for sure that there was almost no, you know, there's no obvious pus left. Okay. So the question is, can we generalize this now to the ED? The ED, most of the time, it's not under general anesthesia. We may not be sure that we can actually adequately get out all the pus. Maybe it's different bacteria, right? Those were anogenital abscesses, anaerobes, gram negatives. Now we're talking about MRSA. So what we did is we did a randomized clinical trial at 2 different centers, one in Stony Brook, the other in Washington, D.C., where we basically randomized patients either after they were drained through a small incision. We randomized them to primary closure with suturing versus secondary closure. What basically we did is we put one vertical massive suture in the middle of it, and physicians were allowed to give antibiotics if they wanted to. And basically, what we found is that there was no significant difference between the primary and secondary closures. The failure rates, actually the success rate, I'm sorry, the 7 days actually success rate. So it actually was slightly higher in patients who had primary closure, but it wasn't statistically significant because it was a relatively small study. And the recurrence rates at 7 days were also less, but not significantly less in primary closure. So people do well, okay? But the key is that in this study, we looked at the average length of the incision, it was 1 centimeter. Okay? So if you have a tiny laceration, how should you treat a really short laceration? Does it need to be stitched? No, it doesn't need to be stitched. It'll heal just as fast. So with small incisions, it doesn't matter if you suture the abscess or you don't. They're small, so you're not going to really see a difference in the healing. With very long incisions, if you do long incisions for whatever reason, then it makes sense to suture them up because they're going to heal faster and better. Okay? And especially over areas that may be important cosmetically, you want a smaller scar. But if you drain them the way I suggest, you look and see where the pus is. You see if there's loculations. And then you make a stab wound, a relatively small incision over the area of interest. And if you know there's several pockets, you can go through that with your knife, with your clamp, whatever it is. You could break down those loculations. And you can also do that under ultrasonic guidance. You could still get all the pus out through this very small incision. And then you don't really need to suture it because small incisions heal really, really fast. So here's an example, incision, drain the pus, vertical natural suture. So that I would do maybe on a very long incision, over the face possibly. This is one patient in the study. Can't really see it very well, but he had an abscess, we drained it, sutured it, and that was done. That was under ultrasound, of course. What about packing? The question is, again, why do we pack? Why do we pack abscesses? What's the purpose of packing abscesses?
Theoretically, keep it open.
Keep it open because what's going to happen?
Continue.
Continue drainage, and the patient's going to die, right? Okay. So, and as I mentioned, there's a difference between just putting a little bit and really shoving it inside there. This is a study where basically they enrolled 48 patients with a simple abscess that was INP. They all got Bactrim, and they basically randomized them to either packing or no packing, and there was no difference in the need for a second intervention in 48 hours. So the rate of recurrence was the same. And what they found was actually that there was less pain when you didn't pack it. So packing is very painful, and it doesn't really do anything. And the problem, as I mentioned, packing, when should you pack an abscess? Does anyone know? When would you pack an abscess? If it's bleeding a lot. So the packing is meant to tamponade. So if you do, you happen to nick a big vessel and the patient's bleeding and bleeding from the abscess, the purpose of the packing, and then I do put in a lot, the purpose of the packing is to tamponade the blood. That's the only reason to put in packing. Now, if there is drainage and you want to make sure it's still coming out, you can put in a small lick, maybe half an inch, and we use the iodoform or we use any type of gauze. And why do we use like a gauze? What's the purpose of that?
Wicks.
Wicking, right? So it's capillary action. You get wicking of fluid out of that. And so, yeah, you can use it. I don't usually use it. This is another study now. This was in younger patients where they randomized them to packing or no packing. And in this study, actually, they showed that there was a slightly less recurrency when they packed it. Actually, the success rate was slightly better, but it wasn't statistically significant. So I don't routinely pack them, I don't really think there's any reason. So now the big question always is antibiotics, all right? So this is a study which is relatively contemporary in the age of MRSA. So they decided that they were going to randomize patients that they graded to placebo or antibiotics, but they specifically chose an antibiotic that was active against MRSA, which is the bacterium. So 212 patients, nice size study, 90% follow-up, 7 days, which certainly is not bad at all. Basically, they looked at the 7-day failure rates and recurrence rates after 30 days. And basically what they showed was that there was no statistically significant differences in the rates of recurrency and failure. Although there was a trend in favor of the antibiotic, it was not statistically significant. And they concluded that you really don't need to give those antibiotics. Now, there are a bunch of other studies that have come out using various antibiotics in the past. Keflex, of course, is not a very good choice. It's a first-generation cephalosporin. The resistance MRSA is pretty high, so that really wouldn't have been a good choice. Another study that looked at Bactrim, and again, in both of these studies, the cure rates are no different between giving antibiotics or not. And so we recently conducted a meta-analysis, which I think you probably rejected from ADM, Emergency Medicine Journal, appropriately because it wasn't good enough quality for ADM, because it was relatively small. It was 4 trials, very heterogeneous, but included 589 patients that were randomized to placebo or to an antibiotic, and it was a mixture. You see Bactrim and cephalosporins, and basically what the meta-analysis showed is that there was no difference in the outcomes, favorable outcomes, at 7 days or at 30 to 90 days. So antibiotics in general don't make a difference. They don't make a difference whether you choose the right antibiotics or the wrong antibiotics. Most people do well without it. So another question, of course, is what is the role now of antibiotics in general in skin and soft tissue infections? So as I said, most patients I just drain it, especially if you get pus, and you can send the patient home without any antibiotics. If there's a lot of cellulitis, if the patient's immunocompromised, there is some studies, but not all studies, from the pediatric literature that suggested that there were higher hospital admission rates with large abscesses. That doesn't mean that they were admitted appropriately. That's the problem with admission rates, because just because you admit a person doesn't mean that they need to be admitted. So it could sometimes be a self-fulfilling prophecy, right? You think that larger abscesses are worse, so we'll admit everyone with larger abscesses. And because we admitted a lot of people with large abscesses, we just proved that they're worse. So it's really not a very good logic, but some people think that large abscesses should be treated with antibiotics. And certainly, if you're going to give antibiotics, look at your own resistance rates. You know, every hospital, generally every year, they will publish an antibiotogram where they show the resistance rates for various antibiotics and organisms. Most places, certainly, clindamycin or Bactrim are still pretty good. These are the antibiotics that are recommended by the Infectious Disease Society of America. So clindamycin, Bactrim, doxycycline, of course, in older kids. Yes?
Do you consider diabetes immunocompromised?
Yes. For the purposes of abscess, yes. In IV patients, you know, vancomycin is the gold standard. There are a bunch of newer antibiotics, and linezolid and daptomycin, clindamycin, again, which you could consider and use. Now, the question is, what do you do if there's an abscess of cellulitis? And that's really the dilemma that we have a lot, because there's an abscess or an abscess that's not yet mature. There's a lot of cellulitis. We know, as you guys mentioned, that non-purulent infections are generally streptococcus. And so they might be covered by different organisms. And so what do? You give them clindamycin would be a good choice, maybe because it covers strep and staph. Or do you have to give them Bactrim, which covers staph, but doesn't cover strep, and then they had the first-generation cephalosporin. But there's really no evidence that patients with cellulitis should be treated any differently with antibiotics. And so recently, there actually was a fairly large study that was supported by the NIH, where they basically took 524 patients, of which a significant proportion were children, and they had to have either cellulitis or an abscess or a combination of the two. They randomized them either to clindamycin or Bactrim. And 30% had an abscess alone, 50% had cellulitis alone, and 15% had both. And Staph aureus was isolated in about 40%, of which the majority were MRSA. So kind of a mixture of what we see a lot, but we're not really sure is it an abscess, is it cellulitis, is it both? As I said, ultrasound is very helpful, but basically what they showed is that the cure rates were pretty high, and it didn't matter if you gave them clindamycin, or you get which covers both organisms, or you give them Bactrim, which only covers staph. Okay? And they did a breakdown, but what if you only had an abscess? What if you only had cellulitis? What if you had both? What if you were a child? What if you were an adult? It didn't matter. In all subgroup analyses, the cure rates were the same for clindamycin and Bactrim. So it probably doesn't matter which of those antibiotics you choose. As I mentioned, generally it would be the patient with extensive cellulitis. It's got a systemic illness, fever, they look sick, or they're failing treatment. So what about wound cultures? Some of you mentioned that you get wound cultures. At the beginning, I think wound cultures were very, very important because that helped us identify the organism. We know it's MRSA, we know which isolates they are. But in reality, now that everyone knows that, there's really no reason to get a culture. And as we said, it doesn't really matter if it's staph or strep. Most can be covered by clindamycin or Bactrim. It doesn't matter. So I don't routinely get wound cultures. Certainly, I think if you're admitting a patient, they're failing antibiotics as an outpatient, it makes sense. If there's an outbreak and you want to be sure what the outbreak is from, you might consider it. But in general, I don't recommend routinely getting any cultures. Now, decolonization is not a word that we really are aware of in the emergency department. We have enough that we have to worry about. But certainly, especially if the patient comes back again and again to your emergency department with recurrent abscesses, you need to consider that they may be carriers. And there are some strategies that have been studied to try and reduce recurrent infections in patients who are colonized. This is one study where basically they took 137 patients that were decolonized, and they found that 32% had recolonized. So the rates of recolonization are pretty high. Okay. Another study looked at intranasal mutagorocin or Bactroban in colonized soldiers, and they didn't find any changes in infection rates. But certainly it's something to consider with recurrent infections. This is a study, two studies that basically looked at various strategies, and certainly it makes sense to avoid sharing items like razors, brushes, towels. Some strategists have recommended 2% Bactroban to the nose twice a day for 5 days, 4-hexadine, 4% wash with all body parts except the face or open wounds. And if the patient is still getting them, then some people suggest maybe a 10-day course of antibiotics with anti-MRSA activity if they have recurrent infection. So certainly this is something you can consider in ED. You could refer that patient to infectious disease if you want to. But if a patient keeps coming back with infection, don't just bring the abscess and send them home. Consider what can be done to try and reduce the recurrence risk, because a lot of these patients will come back again and again. Okay. So to summarize, what should be the management of soft tissue infections in the era of MRSA? As I mentioned, the mainstay of treatment is still IND for cutaneous abscess. You've got it's a surgical disease, you need to remove the pus. Okay? If it's very severe, very extensive, there's a lot of cellulitis, the patient has a lot of comorbidities, they're not responding to the IND, then you should consider antibiotics. Clindamycin or Bactrim are certainly good choices. Prophylaxis is required in patients who you're going to drain an abscess who are at risk of endocarditis. You always want to know if the patient has any prosthetic valves, if they have rheumatic heart disease, and ask them if they routinely get prophylaxis before they have dental extraction. And then you can pre-treat them with an antibiotic with MRSA coverage, about an hour before you do your drainage. This is the most recent guidelines that came out from the Infectious Disease Society of America on how to manage skin and soft tissue infections. As you can see on the far right, it says purulent. If it's mild, IND only. If it's moderate, they say IND, and consider culturing and starting some empiric antibiotics. If it's severe, then you need to IND, admit them to the hospital, and give them IV antibiotics. That's pretty straightforward. If it's a non-purulent infection, you think, well, it's probably more likely cellulitis. If it's mild, you can give them some oral antibiotics, mostly against streptococcus. If it's more moderate or severe, then they might need to come into the hospital to get IV antibiotics. And we're not even going to talk about metrotizing fasciitis, which is a completely different animal. Again, as I mentioned, it's important to try to prevent and educate our patients. So it might be a kid who's playing, football in high school, or a wrestler or something, where you have to make sure that they wash, not share various towels and stuff like that. And certainly consider, if you have big outbreaks, that it might be worth getting cultures to see if there's any change in the bacteriology. So I'm going to stop now. I think that was, this is pretty clear cut. You wash your hands. Do you guys wash your hands in patients? By the way, what's the best way to clean your hands? Is it the alcohol crack, or is it the soap and water? It is soap and water, and to be effective, you have to wash for at least 30 seconds. Some people say 2 minutes. So why do we all use those alcohol-based foams? It's a very convenient, easy to use. So what they found is it's better to use a suboptimal method than no method at all. That's the truth. But still, if you want to do what's right for the patient, you should be washing your hands before and after treating them, especially if they have abscesses. So bottom line, take-home message. These are the tweets. Where's the tweeter, right? Hashtag reliable, then physical exam. The definitive treatment is IUD. Don't use needle aspiration to exclude or treat abscesses. Packing should not be routinely recommended, nor should the antibiotics. You can drain most abscesses through small incisions, and you should always consider procedural sedation and encourage wound and environmental hygiene. Okay, so are there any questions about abscesses? Yes?
Quick question about after you do your stat incision with the lead, what's your feeling like irrigating?
You can. There's no study on irrigation, so I really can't say. Sometimes I do, sometimes I don't.
It makes us feel better.
It makes us feel better, but it also is very messy. I think, again, just like everything, remember the body, the immune system, and the microbes are in battle. And it's always a balance. Once you shift the balance in your favor, you're going to win the war. You don't have to kill every single soldier. If you knock out enough of their planes and their tanks, eventually you're going to overcome them. So I don't think you have to get out every single white blood cell. I guess it depends how much comes out, how viscous it is, how smelly it is. Right? Okay, you had a question down here somewhere? Yes.
In the patients that you're not packing or having them return, how often are you having them return for?
But all patients should have follow-up, right? Either in the emergency department with their doctor. Remember that a lot of physicians now, primary care physicians, they don't want to deal with abscesses. They haven't seen an abscess in a long time, like suturing, laceration. Most primary care physicians don't even have suture removal kits anymore, right? They can't deal with it. They're too busy. So I usually have them come back. Okay. If I pack them, which I rarely do, then I don't have them come back the next day. Because if you have them come back the next day, you remove the packing, there'll still be drainage, and you're going to pack them again. So I usually say 48 hours, 48, 72 hours. If I find that the patient really is not immunocompromised, they're fairly reliable, you really got a lot of pus out of there, with this big orange, and now it's completely flat, they look really good. I kind of leave it up to them. I say to them, you should come back if you have any concerns, and certainly come back if it's reaccumulating, if you have fever. But, and then I generally, if it's open, then I just let them shower, they can wash it out. I don't have to irrigate it for them. They can irrigate it with soap and water, in the shower. But they should all get follow-up and warning signs, when to come back. If it accumulates, it becomes septic, cellulitis, and pain control. If you do an adequate job of draining the abscess, generally there's not a lot of pain. Because a lot of the pain is from the pressure of the pus within the contained tissue. And once you relieve that pressure, there really should be minimal pain. So they don't really need to go home on narcotics.
So I have a question. Do you have any tips on if we're not using procedural sedation on getting anesthesia? Do you believe
Yeah.
in bicarb or ring block?
Yeah,
or?
well, that's, procedural sedation is good, but usually what I will do is I will numb up the skin itself over the area where I think I'm going to make my decision, okay? So, and I usually start with a 30 gauge needle or 27, a really tiny needle. You raise a little bit of a wheel. You can buffer it with bicarb if you want. I don't routinely do it. Use a very small needle. But you have to raise the wheel where the incision is going to be. And you can either then make your stab incision and then go through that incision and now give a local anesthetic into the tissue around that. Some people do a field block where you actually anesthetize a circle around the entire abscess and then just over the incision site. You can do regional anesthesia, certainly if it's an area that's amenable to that, it's an extremity. Yes?
What would be the risk of inserting a needle through abscess into the surrounding tissue?
In theory, yeah, in theory there is a risk, but I don't think there's any study that shows that there is an increased risk of sepsis. I mean, surely the patients get bacteremia when you just cut, right? When you cut through that, they're probably going to get bacteremia, most of them. Okay, because you're opening up blood vessels just by making the incision. Now pus is mixing in those blood vessels. So as it is, I'm sure there's going to be some dissemination of bacteria. But that's why I'm saying some people will prefer to do a field block around it. As I mentioned, I usually go through because I don't want to, it's very painful to do that field block. One of the problems, what a lot of people do also is they'll take the needle and they'll go into the abscess and they'll poke around, and inject a lot of lidocaine. The problem is, remember, we said most of the pain is from the pressure. So if you haven't relieved the pressure by draining it, and you're now inflating that more and more, it's much more painful. That's why I prefer the technique where you make minimal anesthetic just over the skin. You make a little puncture wound, then that doesn't hurt. And now you release a lot of pus, and now if there's areas where you're going to be probing, then you may need to add an anesthetic. Sometimes that's all you need. You do that puncture wound if it's just one cavity, one accumulation, and it comes out fairly easily, then you don't really need to do any more anesthetic. Okay? Any other questions? Yes.
In relation to antibiotic use in simple abscess, no associated
Yes.
skin and soft tissue infection, all the studies, I think, have exclusion for axillary or genital abscess or things in the perineum, as well as immunocompromised. What do you do with diabetics with abscesses?
Well, diabetics, we said, I usually will cover them. But if it's in the axilla or perineum, I don't put them on antibiotics.
No. Okay. Is there any data on that? No.
A lot of the studies that looked at primary and secondary closure didn't use antibiotics.
Mm-hmm.
They didn't see complications. So some of the studies do include them, some of them don't include them. But again, I don't think that the location matters. So if the patient has a simple perianal abscess, you could bring, I don't give antibiotics unless they're immunocompromised. And yes, diabetics I usually do include. Okay. So thank you very much for hosting me.